Okay, this is just coming to the end of my third year of a part-time PhD, so I've got another 2 years to go, so I wish I was coming to the end, but I'm not.
Well, you're in for half.
I've just actually got to the point where I've analysed the data, and I think what I'm about to show you today has actually been quite surprising for me, because it's not what I expected to find, and I think you will probably find it quite a surprise as well. Now, we're repeatedly reading in the literature that obesity is becoming a global epidemic. It's a key area of concern, particularly around about public health, primarily with its association with diabetes and coronary heart disease. The tool that, the most common tool used to calculate the BMI is your weight divided by your height squared. However, this tool itself is debatable. We can all agree it's easy to use, it's quick to use. However, it's a tool that was developed for the Caucasian population, whereas we know that the Asian population have a higher risk at lower BMI because they have a higher fat distribution. It's also a tool that doesn't take into account your fat and your muscle ratio. So if you looked at some athletes who, visibly, you could see that they're quite muscly, they actually may as well fall into perhaps an obese category based on the BMI, World Health BMI classification. However, it is a tool that we use at the booking clinic for women to actually classify them into one of the classification section, either ideal weight, underweight, overweight or obese, and then we start moving into class 1, class 2, class 3 of obesity. So from the booking clinic, women with a BMI over 30 are actually given that label, high risk. And the unit that I'm attached to actually places a sticker on the women's notes, and it's a sticker saying contact anaesthetist as soon as this woman comes in labour. So they're practically given a high risk sticker on the front of the notes. And if you look at the CMACE and the RCOG guidelines on the management of women with obesity and pregnancy, it does encourage midwives to have the conversation around about risk at the booking clinic. And from here, when the women are labelled high risk, they go down a medicalised care pathway, okay, with more medical surveillance. Now, when we look at the risks associated with obesity during pregnancy, the risks are linear, i.e. the higher the woman's BMI, the higher the risk that she actually has. She's got a higher risk of miscarriage. Now that's thought to be around about the insulin resistance. She's got a high risk of gestational diabetes, thromboembolism, preeclampsia. She's also got a high risk of caesarean section. Okay, now that may well be because of the complications that she is at risk of. She's also got a higher risk of postpartum hemorrhage. Okay, women who are obese are less likely to actually initiate breastfeeding, and they're less likely to be successful at breastfeeding. The risks not only exist for the woman, okay, the risks exist for the baby as well. There's a high risk of large for gestational age, okay, which again predisposes more to a higher risk of having shoulder dystocia. We've got a high risk of stillbirth, congenital abnormalities. The congenital abnormalities has been linked to the higher risk of diabetes in women who are actually obese. And we also have, there is evidence to show that obese women, they're probably a bit more difficult when to actually get an accurate image during ultrasound scanning. So maybe the higher risk of congenital abnormalities is that the fact we're not picking them up at an earlier stage. They're more likely to have babies admitted into neonatal units. And all these risks are actually based on an early pregnancy BMI. So what we don't know is what happens to women who perhaps have a normal BMI but put on excess weight during their pregnancy and maybe fall into that obese category when they're midway through the pregnancy. Okay, so we don't actually know what risks these women actually have. Now, most of the research around about obesity and pregnancy, it focuses more on quantitative research. It focuses more on the physical risks to the woman. Hence, I've seen a gap in the literature looking at what does the woman perceive a risk to be? Okay, how does she feel with that high risk label? So what I then chose to do was to use a qualitative study with a longitudinal design, i.e. I was going to follow these women throughout the pregnancy. I actually collected the data and I used a method known as IPA, Interpretive Normal Analysis, which basically is me looking at the woman as an individual case study, looking at her lived experience of being high risk and interpreting that experience. Okay, so what I did was I recruited 7 women from a community midwives booking clinic. I had to apply inclusion criteria, and I wanted to include all women with a BMI over 35, okay, all women over the age of 18. They had to be able to speak and understand English. Now that's purely from a funding point of view because I was a PhD student and I didn't have funding for interpretation. Exclusion criteria: unwanted pregnancy, any known fetal abnormality, or any known severe psychological disorder. And the way I screened for that is on day, once the woman had verbally consented to the midwife that she wanted to take part in the study, I then arranged to meet the woman 3 to 5 days after that. And I got to sign a consent form and also to complete a hospital anxiety depression scale, which is a very quick 10 questions, and you basically scale the questions and you can tell there and then whether this woman had a likelihood of anxiety or depression. And I excluded women with a scale above 8. So what I did then with these 7 women is I interviewed them using a semi-structured interview at 20 weeks, 34 weeks, and then in the postnatal period. Now I chose these trigger points because 18 to 20 weeks is the time that most of women want to opt for a fetal anomaly scan. That's the time period. And that's also the time it's a trigger for the midwife to talk about, this is the reason why you're having your scan, is to detect any fetal abnormality. So it might flag up the risk to the woman. 34 to 36 weeks, the time where we should be discussing birth plan with the woman. Because when the women go down this midlife care pathway, the ASIO guidelines for women with a BMI over 35, they recommend that these women give birth in an obstetric unit. So already we're excluding these women from home birth. Some units, the birthing centre, will exclude women with a BMI of 35 and over, are starting to be affected because of their actual BMI. And then I went back 10 to 15 days postnatally, basically because it had given the woman time to reflect on her whole birthing experience. So in total, I had 21 interviews. Now, I'm going to tell you the outcome first, before I talk about the actual the data analysis. I recruited 7 women. The BMI ranged from 35.9 up to 43. Out of these 7 women, 2 had a vaginal birth, 3 had an emergency section, 2 had an elective section. Now I'm putting brackets elective because they were already in labour and they were given a choice. Do you want to carry on or would you rather go for section? So it wasn't a true elective section. 2 had a postpartum hemorrhage, 2 had preeclampsia, 1 had a wound infection, 1 with obstetric cholestasis, 2 had admissions into neonatal units, and 2 women breastfed out of the 7. So you can see from the outcome here, these are all risks that are associated with obesity during pregnancy. Okay, when I analysed the data using IPA, I was able to identify 4 themes. What I did was I looked at each woman on their own as a case study, and then I looked at time points. Was there any change in the 3 time points? I couldn't find any real significant change. The only significant change I could find was perception of risk, and I'll come back to that. But these are the 4 themes. Okay, women's perception of risk, women's perception of control during childbirth, a perception of her own body image, and a perception of risk communication. Now, bearing in mind all what we've seen, the birth outcome, what I was surprised to find that is none of these women at the end of their pregnancy felt they were at risk. 2 women at the beginning of pregnancy felt they were at risk. By the time they got to the end of their pregnancy, they didn't think they were any more at risk than anyone else. And basically looking through the data, I think it's around about the way the women construct the risk. One thing that has become quite clear is they don't ask the midwife. They don't talk to the midwife, and the midwife doesn't talk to them. The women look at the internet, they'll find information off the internet, but they will look at friends and family. They'll ask friends and families, and they'll look at friends and families. If they've got friends who've maybe had lots of complications, but they've got a normal BMI, some of the women were saying, well, they women have got the same complications and they've got a normal BMI, so I'm not any more risk than the women there. They also, they felt that they could ask the midwife, but they just didn't ask the midwife. They prefer to ask their friends and family to construct their actual risk. So their own self-perception was that they didn't feel that they were at risk, and they didn't actually prioritise the risk over the risk of smoking, the risk of age, in relation to infertility. When we looked at control, the women very much wanted to be in control, but by the time they got to 34 to 36 weeks, the women actually really wanted just to feel safe. Okay, they just wanted to feel safety in themselves and safety for their baby. So they actually started to welcome medical surveillance. They welcomed more scans, they welcomed more trips to the daycare unit, and that was all centering around about how safe they actually felt. None of the women actually felt that the choice was compromised, but what they did highlight was that they preferred continuity of care. Okay, I had one woman who actually went to the metabolic clinic because she had a BMI over 40, and she was quite vocal in saying that she felt her care was quite fragmented. She would have preferred to have stayed with the midwife, the community midwife, and had all her care from the community midwife. Body image, they didn't feel that they were obese, okay, because society on the whole has normalised obesity. So the women themselves didn't actually feel themselves that they were obese, and some of them were quite upset when they were classified as obese according to the BMI category. They associated being fit and healthy with not being at risk. Women's perception of risk communication, it came over very clear that none of the health professionals, not just midwives, nobody talks about risk. Nobody mentions that all throughout their pregnancy, and some of these women got actually quite angry because they were now into their second pregnancy with a higher BMI, and they knew they had a high BMI in their first pregnancy, and nobody had actually wanted to talk about the risk that they actually had. This is a quote from participant number 5, and this is the quotes at different time points. And you can actually start to see her risk perception starting to change. This woman, at a 20-week appointment, and again this leads back to midwives communicating risk. When this woman was told she was high risk, she was left thinking that when she shut her eyes at night she was going to die. For 20 weeks this woman didn't sleep because she thought she wasn't going to wake up, because she was told she was high risk. It wasn't until she went to the metabolic clinic and they explained the term high risk means you're at risk, but you're not necessarily more at risk than basically high risk, sorry. But by the time she got to 34 to 36 weeks, her risk perception had started to actually change. Now, this woman herself had a cesarean section of obstetric cholestasis and a baby admitted into the neonatal unit, but somehow she gets to the end of her pregnancy and you see the quote at the end, "I don't feel I'm high risk." So, throughout the interviews, I asked, some of the questions I asked some of the women to actually give us a solution to the communication. Because if we as health professionals are not talking risk to the women, they're not perceiving themselves to be at risk, they're not going to make any behavioural change, particularly for the next pregnancy. And as I say, it became quite clear in all the interviews that health professionals, not just midwives, we're not talking about risk, we're avoiding that risk discussion. Now, continuity of care is a key element here, I think, because looking at literature talking about risk communication, midwives don't want to talk about risk because they don't want to put blame onto the women. And some midwives find it difficult to talk about risk, particularly if they've got a high BMI themselves. So perhaps continuity of care, where we've developed a relationship and somewhere along the pregnancy continuum, we can maybe start to engage in conversation with the midwife, with the woman about her BMI. Now, one of the things that did come back was the woman said was, "It's too late to tell me when I'm pregnant because I can't do anything about it. I might be able to do something about it for my next pregnancy, but for this pregnancy, I can't actually do anything about it." And when I asked the woman about what would you like to see, how would you like the health professionals to approach it, one of the women said, in her own words, "I know I'm fat, so be direct and tell me." Now, that communication strategy, I wouldn't recommend that communication strategy for everyone. But there's something about being a wee bit more direct, and rather than avoiding the conversation, we maybe have to be a wee bit more direct but sensitive in how we actually communicate to these women. And perhaps we need to start in the pre-adolescent stage. Okay, go into schools and talk about the risks of obesity. And actually, one of the women did say to me, you go into a health centre, you see posters about smoking, you see posters about alcohol, you see nothing about obesity and pregnancy. So there's key messages there about how we actually look at the health promotional strategy. Some of the recommendations from women were, why don't we use women's stories? Why don't we use social media? Okay, why do we not have a midwife on social media site NetMums? Because when I asked a lot of the mums, if you're not asking the midwife for information, where are you finding this information? They said, we go on to NetMums and ask a question on NetMums. So again, this might be a recommendation that we might have to think about in getting the health promotion message across, rather than the traditional leaflets, posters, maybe going on to social media. Okay. That time up. Okay, so that was only one recommendation for one theme. I've got another 3 themes to go with recommendations. Thank you.
Well done.